my name is Dr. Stephen Liu. I'm an associate professor at Georgetown University, director of thoracic oncology. And we've learned recently that the randomized COCOON trial did meet its primary endpoint. COCOON is an interesting study. The endpoint primarily is one of toxicity and quality of life for patients. This looks at the combination of amivantamab and lazertinib, a combination that has shown activity across different settings for the treatment of non-small cell lung cancer, particularly in those with EGFR mutations. And COCOON really looked at a preventative and proactive support strategy to minimize toxicity. Really a patient-first approach, one that I applaud in this study. Patients receiving amivantamab, an EGFR MET bispecific, and lazertinib, a third-generation EGFR TKI, randomized to just sort of standard basic precautions and reactive management of certain toxicities, our general approach with most agents, compared to an experimental proactive approach, which used a four-pronged attack to delay or prevent or reduce the incidence of certain types of toxicities. The intervention here were oral antibiotics from the beginning, were topical antibiotics, were chlorhexidine rinses of the nail beds, and of course, certain types of emollients and moisturizers. And the thought here is that these interventions upfront early, before patients developed dermatologic toxicities, would reduce the incidence and severity of certain adverse events related to this regimen. I like the approach. We know from other studies, including Mariposa, that the combination of amivantamab and lazertinib is a very effective one. In fact, in that phase 3 Mariposa trial, we learned that that combination was superior to osimertinib, not just in terms of improving progression-free survival, but actually leading to a survival benefit. And that benefit is always balanced by the toxicity. And that window, the therapeutic window, really is determined by how effective agents are and how toxic they are. When we're adding more drugs, we will add toxicity. The question is, how much more efficacy will we see relative to that toxicity? And to widen that therapeutic window, we can either further increase the efficacy, which we always want to do, or we can decrease the toxicity, which we also would like to do. That latter approach, though, not really focused on as much as we'd like. And so I think this is a very nice approach. We learned that this was a positive intervention. This is a relatively low cost, especially upfront, kind of intervention, one that we'd like to see more of. So the questions we have is sort of the granularity here. Which adverse events were really helped from this approach? We know that rash and paronychia are common toxicities. How much of an improvement did we see? When did we see it? Was it shared by all patients, or are there specific patients that benefit more? And how easy will it be to adopt an intervention like this? So I look forward to seeing these data presented in their full entirety. Just to summarize, this combination of adding a bispecific antibody to a TKI improves efficacy, but the hesitation with implementation has always been with regard to toxicity. And while not necessarily life-threatening, they have a significant impact on day-to-day quality of life and in terms of how patients are feeling and tolerating that treatment. So any efforts to reduce the toxicity, whether it's with a dermatologic approach, as we saw in COCOON, whether it's trying to prevent infusion reactions, as we saw in the single-arm SKIPPR study, or whether it's really trying to reduce some toxicities almost altogether, and that we saw with the subcutaneous formulations, which really do seem to have very little risk of infusion reaction. So establishing that this is an effective regimen, I think, is an important first step. And now finding ways to reduce the toxicity, I think, will open the roads to really allowing for more widespread implementation.